Well, it's a very important question. Colonoscopy is the inspection of the colon, which is a large bowel, with the help of a slim telescope. Uh, uh, this is to diagnose any bowel-related problems, such as if somebody's having a bleeding from the back passage, or they have a diarrheal symptoms, so they may feel bloated and have abdominal pain, or change in his bowel habits. And it's particularly important if there's a family history of colon cancer. Or sometimes we do a FIT test, which picks up little blood in the stool sample. If somebody is FIT positive, then they require a colonoscopy. So it is to diagnose any bowel-related conditions, such as colitis, such as a polyp in the colon, and also to rule out a colon cancer. And also it allows us to remove polyps, which reduces the risk of colon cancer. So it is an inspection of the colon with a telescope. Well, on the day when they come, we give them mild sedative that we call a snoozy juice to relax them a bit. We place a little plastic needle in the arm to give that little injection. So when they're sleeping on the left-hand side, we pass the telescope from the back passage and to inspect the bowel all the way to where we find the appendix, which is the end of the colon. Conventionally, colonoscopy is done, the endoscopist uses gas to distend the bowel and shine the light and find the way around to the cecum, which is the end of the colon. But it's a new technique that I pioneered with a few of the colleagues, is the underwater colonoscopy, in which we switch off the gas and we use a bit of a water jet to find our way around. And many patients find that underwater colonoscopy almost painless, and they don't feel bloated afterwards. So the satisfaction for the patients is quite high with underwater colonoscopy. What's most important part is the bowel preparation for the patient. So I spend a fair bit of time to go over the bowel preparation. So they have to stop taking high fiber diet a few days before the procedure. Then we give them a very strong laxative that they have to take one packet the night before, the one on the day. And it's very important that if they are taking any iron-containing medicines to stop it, sometimes strong painkillers, which makes the bowel sluggish and makes the bowel prep very difficult, we advise them to stop it. Most important aspect is the one, if patients are taking blood thinning medication, it's very important for them to inform us, because we have to stop these medications at least 2 to 3 days before, because that allows us to remove any polyps. Otherwise, there is a risk of bleeding. So it's important for us to communicate with the patients very well. The drugs they're on is important for us to know. The diet they're on is very important for us to know, and to understand the bowel preparation. Because all that makes the colonoscopy a very effective procedure, and yield of the procedures is very high if we prepare a patient very well. Colonoscopy takes about 20 to 30 minutes. It's depending on if we see a diagnostic procedures, it could be done within 20 minutes. But if we come across any polyps in the colon to remove it, it may take a bit longer. But most procedures are done between 20 and 40 minutes. And because patients are consciously sedated, so most of the time we can have a conversation with the patient during the procedure, but they're very relaxed and comfortable. And after the procedures, they are recovered in the recovery room. And usually they're up and about within the hour. They get fed afterwards. But because they had a sedation, they're not allowed to drive for 24 hours, and somebody has to look after them, because the sedation can make them a bit forgetful. But physically, they are well enough due to any tasks an hour after the procedure. Well, this is very important questions, and it makes the part of the consent process when we consent this patient. So we do quote risk of abdominal pain, discomfort, occasional bloating, which are the more common sort of side effects of what we call minor from the procedures. Usually occurs in about 5 to 10% of the patient. Serious risks such as bleeding or perforation, which is not knowingly making a hole in the bowel, are fortunately extremely rare. But when we do a therapeutic procedure such as removing large polyp, then it can run risk up to 1 to 2% with serious complications for colonoscopy. For diagnostic colonoscopy, risk is extremely low. And I have done almost between 20 and 30,000 procedures in my lifetime. And I feel this procedure is quite safe. But we do discuss this very carefully because every patient is different. If a large polyp to be removed, then it's careful discussions goes on the complication. But most of the time, it's just abdominal bloating, occasional cramps. It shouldn't be a painful procedure. But when you do a therapy, then there is risk of bleeding and risk of causing damage to the linings of the bowel. Well, this is also an important question. The bowel cancer screening program now have extended the age, and that eventually they would like to move it to age 55. But in North America, for example, they promote doing colonoscopy after the age of 45. Certainly, it needs a lot of resources to do this in the NHS. But now we have seen the colon cancer trend is coming downwards to a younger patient. It was a thing of the past that we used to say the colon cancer in after the age of 60, that we're seeing young patients as young as in their 40s to having colon cancer. So it's important as the one if somebody has change in bowel habits in the way of diarrhea, constipation, bloating, abdominal pain, bleeding from back passage, any change in their bowel habits, they have a strong history of a family history of colon cancer, they should come forward to have a colonoscopy.